So today we have a 80-year-old male patient. He has some comorbidities like coronary artery disease, hypertension, non-alcoholic steatohepatitis. He has undergone 2 coronary interventions in the past, in 2011, 2013, and 1 renal artery stenting. He presented to us with progressively worsening dyspnea on exertion. Currently he is in NYHA class. Angio was done last month. It revealed triple vessel disease, but most of the lesions were insignificant, so we have planned medical management for the coronaries. 2D echo shows normal LV function, ejection fraction around 55%, severe calcific aortic valve stenosis, and mild aortic regurgitation. On echo, the mean gradient is 50 millimeters of mercury and maximum velocity is 4.7 meter per second. And valve area by VTI method is 0.7 centimeters square, suggestive of a severe calcific aortic stenosis. His STS PROM score has been calculated. It comes to 8.6, meaning he is at a high surgical risk. So we got a CT analysis done, and after carefully assessing the CT scan, we decided that TAVR is the way to go for him. Let's go to the next slide, please. So this is the baseline CT scan. We have a good sized annulus, a good coronary heights. The minimum annulus diameter is 20.5. Next slide. And it's a bicuspid aortic valve type 1A. We see that the right and left cusps are fused by a raphe. So in such cases, when we deploy the valve, there is high chance that the valve gets shifted towards the non-coronary site. If there is a risk of coronary obstruction, the raphe sometimes helps mitigate this risk. Aortic annulus minimum diameter is 20.3 millimeter. As it's a bicuspid aortic valve, we are going to plan for a pre-dilatation, and pre-dilatation will be done with a 20 millimeter mammoth balloon. Next slide. These are the intercommissural distance measurements, 4, 6 and 8 millimeter above the annulus. And looking at the annulus and the ICD, the anatomy that we have is a flared anatomy. So valve sizing is going to be based on the annulus and not on the ICD. Next slide. This is the calcium scoring. We see that there is moderate leaflet calcification and mild raphe calcification. Coronary heights are good and sinuses are large. Next. Next. These are the angles that we are going to use for assessment and implantation. Next. So this is the sizing guide based when we are using a MyValve balloon expandable valve. Sizing is based on the 3D annular area. When the area that we calculated is 494.9, based on that area, the expected valve size is 26 millimeter with 7.3% oversizing. In bicuspid aortic valves, we try to oversize less compared to tricuspid valves. In tricuspid, our oversizing criteria are around 15%. In bicuspid, depending on the anatomy, sometimes we go to as low as 0%. But this patient has less calcium on the leaflets and raphe, so we are not worried about some oversizing. Next. This is the valve that we are going to use today. It's a made in India balloon expandable transcatheter heart valve, which is being used all over the world, and it is CE marked as in 2019. Next. These are the commissural angles which will be adjusted in the valve before crimping. Next. And these are the vascular access sites. The femoral arteries are adequate in size. Next. This is the baseline echo, mean gradient around 50. Next. In the Plex view, we see a good ejection fraction, a calcified valve and a raphe. Next. Next. Okay, we'll come to this later. To briefly introduce, I am Dr. Aman Patel. I have been trained in structural heart disease intervention under my mentor, Dr. Abdurashid, who is the head of structural heart disease intervention at UMC Heart Center in Astana, Kazakhstan. His center is currently the center of excellence for MyValve in the world. With us, we have Dr. Kintur Sanghvi from New Jersey, and he has been practicing structural heart disease intervention and is also one of the authority in renal denervation. The anesthesia team is led by Dr. Rajnikant Patel, and the nursing staff led by Patel, the technician staff led by Yash Bhai, and I'm privileged to have all of them with me today. The plan is to do a minimally invasive procedure. We just have two arterial access. One is the left radial access for pigtail placement, and we are going to take the major vascular access from the right femoral. Temporary pacemaker we are not planning to implant. We are going to do wire-based pacing with the Safari wire. The patient has two peripheral lines for infusion, and now let's go to the case. Normally in our center we are still not used to doing ultrasound-guided punctures, but Professor Abdurashid only appreciates ultrasound-guided punctures, so he is going to demonstrate it stepwise with the images, how he punctures and how it can help reduce the complications. Dr. Manik Chopra in the panel, he has also been my mentor and has been a very good support since last 2 years in developing our program. So let's go to the case, please, sir.
Thank you, Dr. Aman, for case presentation and for inviting me to this great conference, TRICO. Last year we did several cases for live case here in TRICO conference, and thank you for organizing the committee, for Dr. Tejas Patel. For me it is a great honor to be here with you, and now let's go to start our case. As Dr. Aman mentioned, that there is a different techniques for femoral artery punctures.
Go on the screen.
We could do cut down, we could do crossover technique, we could do ultrasound-guided puncture, and all these techniques are good, and it depends on hospital protocols, but in most cases in our hospital we are using ultrasound-guided puncture, and let's see. Usually before the puncture we check in long axis and in short axis femoral artery. Previously by CT scan we check the femoral arteries. The femoral arteries diameter is enough to do this procedure through the right femoral artery. Now here you could see the common femoral artery and bifurcation very clear. And also you could see here there is no any calcification and plaque in anterior wall. And let's go to the short axis. In short axis you could also see that from the right side femoral vein, when I compress, this femoral vein is compressed, you see, and when I go up, this is the common femoral, and when I go down, this is a bifurcation. Okay, let's go to do puncture. Usually you could do puncture in a long axis or in a short axis, but in a short axis it is much clear. You could see. It is important to see in short axis anterior wall, and it is important to see the tip of the needle. Now
Hello, Dr. Abdul, this is Dr. Anand Rao from the panel over here.
Okay.
So, isn't it better, see, we use most of the time, not most of the time, almost all the time, micropuncture. And my question was to you is, a lot of the interventional radiologists do a linear puncture versus transfer puncture, what cardiologists do. So what is your preference? You do this transverse thing?
Usually we are doing direct puncture with a regular needle.
Okay.
And it is safe, and it is also save the time.
Yeah, but micropuncture is much safer, isn't it?
Yes, yes. Micropuncture is also much safer, but both of them, as I mentioned before, it is up to your hospital protocol.
I think, in here, in this kind of case, there is a lot of planning already happened. So we already have 3 men sure we have a very good understanding of where the bifurcation of the femoral artery is. And then if you are doing ultrasound guided access, I think your question about long axis versus short axis puncture, my concern is that when you do the long axis puncture, there is a possibility that you may end up puncturing higher up. So as much as ultrasound guided access improves the access safety, you also have to be careful, because if you only use ultrasound guided access, you have a risk of higher puncture and then later on concern about the retroperitoneal bleed. But as I said, here we have a 3-man show that really gave a very good understanding of where the femoral bifurcation is. And as long as we can do ultrasound guided access on a short axis just above the bifurcation, the chances of your large bore access being safe is pretty high.
Yes, and now you could see here the tip of the needle. Tip of the needle is above.
So just for the students who are here, young cardiologists who are here, it is very important to see the needle right from the top. You have to see the needle entering right on the top.
Yes, so we have successfully punctured at the center.
Then almost 95% of the time you get into it. If you don't see the needle, if you do ziggy and don't see the needle coming on top of it, then you're not in the same plane, you're in a different plane.
Yes. After the puncture, usually we should recheck our wire.
The wire.
Look, it is punctured anterior wall.
Yes, 12 o'clock position, yes.
Yes, and in long axis, freeze please.
2D.
Also, this confirms the common femoral access. And as Professor said, there is an institutional protocol. In my institution, we always do micropuncture access. Being in the United States, always having liability risk, and common femoral artery access is the most common cause of lawsuits.
Yes.
We use the micropuncture all the time. We put a micropuncture sheath and then take a femoral angio to confirm the access in common femoral artery. But this is a great technique to confirm that you are just in common femoral artery and above the bifurcation.
Yes, above the bifurcation. Here we could also see that we puncture above the bifurcation, and now local full dose heparin.
So the advantage of doing a micropuncture is even after putting the micropuncture sheath and you take an angio shoot, and if you're not happy with it, you can still come out and do a new puncture altogether.
You can make one if required.
That is absolutely correct.
More.
Xylocaine.
And now it is important also to do very good local anesthesia. It will be much comfortable for patient. And now full heparin was done. And usually after the puncture, we could start to crimp the valve. Okay.
When would you give how much heparin? At the time of puncture and then insertion of sheath? When do you choose?
After the puncture.
Okay, even before insertion of the sheath?
Yes.
Full dose?
Yes, full dose.
Thank you.
It's interesting how differences in different sites. We are also micropuncture every time, but I think with a micropuncture, you have to do fluoroscopy, because that micropuncture wire, 1 in 10 times will find the inferior epigastric artery, the deep circumflex iliac, and if you go and put a sheath in, then that's a disaster happening. So for us, every case, we do about 600 TAVRs a year. Every case starts with a CT, then palpation, then fluoroscopy, then ultrasound, then micropuncture, then fluoroscopy. We have to do all of those 6 things for each. But we're always learning and seeing how other people do it in their own efficient way.
So always when you puncture the micropuncture and pass the wire, that's once the wire goes in smoothly, stop there, do a fluoroscopy, pass this wire under fluoroscopy all the time. as doctor was telling, it can go in various branches. So always advance the micropuncture wire under fluoroscopy.
Yes, it depends on protocol.
Had our own share of perforation with a micropuncture wire going into the.
So Aman, you can show the steps of the
Yes, so now our hemostasis plan is using one ProGlide and one angioseal. So I'm first going with the ProGlide.
You can zoom the camera over there and show us what's going on, because a lot of young people want to see that.
Zoom it here.
Did we do the blind dissection to reach the surface of the artery before we insert the ProGlide?
Usually by echo, before the insertion, we could check. By echo, you could very clear to see all arteries, and here we use just a regular wire, and in most cases we use one ProGlide and one angioseal. Here we are planning to using one ProGlide.
Are you comfortable with short wire in the groin, or a long wire would you choose?
Yeah, short wire.
Initially, Dr. Girish, it's a short wire, and then when you want to remove this, then you put a long wire. But I agree with your point, very well made. I would probably take a dilator of 6 or 7 French.
Yes, for sure, yes.
Make a channel so the ProGlide goes in.
Yes, before to insert the ProGlide, usually we use 6 or 7 French. Here. Pre-dilate with a regular sheet, 6 French, and after that go with the ProGlide wire.
So this is facing 12 o'clock if you choose to use single ProGlide and one angioseal, isn't it?
Yes.
Thank you.
As Rajiv said, there are institutional protocol. Within my institution, I always use 2 percloses. So
Two
percloses,
okay.
yeah. And for any femoral access, because femoral access has become uncommon, I always make a very important point to all the fellows. They always have a very good cut and the dissection, because if there is any oozing or bleeding from that femoral arterial access, you want it to come out and not cause a pseudoaneurysm, which can be much more fatal later.
Yeah.
So it's a good idea always to get a good dissection.
Yes, and how often it happens?
Objectively, if you look back, what the literature says, that's what happens. At least 1% of the patients with femoral access ends up getting pseudoaneurysm.
Okay, good. Mm-hmm.
So, Kintur, it's now it's become almost like a standard. I don't know, Dr. Girish will tell us and others also. So one ProGlide and one angioseal has become the standard of practice in most of our places. And sometimes even one ProGlide also. And most of the time you're reversing happening over here. So even one ProGlide also suffices. What do you say, Dr. Girish?
True. I think it depends on, where the bifurcation is. If it is on the head of the femoral, I think you can be very, very confident. But very often if it's above, even in my center, we use 2 ProGlides, not an angioseal. But some of the operators do choose one ProGlide and one angioseal. But we feel any suture based gives you a great freedom to re-access whenever earliest possible.
That is also my reservation against the angioseal, because it invariably changes the vessel wall morphology after the use.
We use two percloses, just like you do. And one of the reasons we went away from the angioseal is our vascular surgeons. They said, please don't use angioseal, because when they have to cut down and go in, it's much more challenging for them to deal with an angioseal problem. But I would say in the US, probably half the centers do this one-on-one, but we prefer the double
Cusp overlap view, please.
At TCT 2025, there was a large series presented from East Asia about the 2 perclose versus perclose and angioseal. And, there was none superior to each other.
And now we're going to cross through the valve with the Lima catheter.
Aman,
Yes, sir.
the valve crossing is done on this 7 French sheath, or you would probably want to put the mammoth sheath and then go through that? What is the...
Now we try to cross first to LV. Now Aman is crossed very fine. With the Lima catheter, as you see, it is very fluoro.
So how do you choose Lima catheter, RCA, AL1? What are your preferences?
We could save, Safari please, we could save much time with the Lima catheter, because when we cross with the Lima catheter, we could measure the pressure through this catheter, and also we could go directly with a stiff wire. It is not necessary to change to pigtail, J catheter, pigtail, it is very safe to go through the Lima catheter with a stiff wire.
Only in certain patients with dilated roots and bicuspid valves, sometimes we require AL catheter.
For us, routine use is brachial and AL1 catheter, which are almost the same shape. But I really like this point that if you're going with the IM catheter, then you can go straight with your stiff wire.
Yes, it is also possible. But wait.
So I routinely measure the hemodynamics in the LV before the valve and after the valve. Do you do that, Professor?
Yes, it is important to see end diastolic pressure in left ventricle before the procedure and after the procedure, and it is very, very important information. And now?
Aman, can I ask you two questions just from a baseline? One is the 12-lead ECG, the conduction at baseline. You didn't tell us, is that normal?
Yes, sir. The baseline 12-lead ECG does not show any conduction system problem. There is no bundle branch block, and PR interval is normal. But if we look at the valve anatomy, there are two risk factors for a pacemaker in this patient. One is the RL fusion. So the valve is going to pressurize on the non-side, which is very near to the his bundle. And secondly, the membranous septum is short.
So if there was a concern at baseline, would you have put a temporary pacing wire in?
So normally if we do this wire-based pacing, then before the procedure ends, if we feel that patient may require a pacemaker, we implant a temporary pacemaker from the jugular access.
Can you save this and replay? It's a beautiful way, disentangled from the mitral apparatus. Is that what you did, Professor?
Yes.
That was an excellent technique.
Yes, in RA view, you could very clearly see the mitral valve, and it is important to fix your catheter and avoid to cross through the mitral subvalvular elements.
And the second question is, do you have echo in the room, or?
Yes, it
we
is
have
mandatory.
a transthoracic echo provision.
Okay.
We are not having a transesophageal this time.
Okay, thank you.
It's funny, Aman, as you said that we don't have transesophageal, because in 2014 when we started doing the valve, we were like 15 people in the room.
Yes.
And we're doing all the sorts of things, and you're showing here something completely different, minimally invasive, only 2 arterial access.
Yes, I'm fully agree. Also, when we started in 2011, it was mandatory to do this procedure under G anesthesia, TEE, and it was really, very, very a lot of additional invasive procedure for TAVR. But now I think we improved these methods, and we could do this procedure with a minimally invasive and still safe. Day later, 18 French. Now it is much easier to cross through the valve in patient with a bicuspid aortic valve in cusp overlap view, because in this side, in pigtail side, you could see the movements of the non-coronary cusp, and from the right side you could see the movement of fused raphe. And now we want to pre-deal with the 18 French dilator.
So Professor, when do you do the pre-balloon shot? Do you do the aortography before, or you do it after the balloon valvuloplasty?
Before, yes.
Aman, it's interesting. I mean, you not put a temporary pacemaker over there. How comfortable are you to pace over this extra small safari wire?
So frankly speaking, when we are doing it here, we are doing a temporary pacemaker, but whenever sir comes here to mentor, he doesn't allow. Even in his center, they are totally avoiding temporary pacemaker.
So Professor, how reliable this can be, and what is your message on it?
Wire pacing, you mean?
Yes, wire pacing.
In most cases, we try to use wire pacing, and if you have independent predictors for full AV block patient with a coronary artery disease, with a right bundle branch block, which could be independent predictor of full AV block, okay, we could use and small LVOT, calcified LVOT, we could use RV pacing, but this patient with a bicuspid aortic valve, and we are planning to implant a little bit higher, and anchoring zone, as you know, in patient with a bicuspid aortic valve, not at the level of annulus, but at the level a little bit higher of annulus, and we are planning to implant like zero implantation, and here we have a very low risk of any conduction system disturbance. Compress.
That's a very, very thoughtful plan because, as you said, the valve is going to be anchored at the bicuspid fusion and not at the true annulus and the baseline EKGs. That's a really good thinking there. We routinely use transvenous pacemaker, but generally speaking, we have a more aged population and some underlying conduction abnormality. But this is very good learning for me.
Okay. Now we insert the Python sheet.
Would you like to pre-dilate the Python?
Yes, fix this one and remove the dilator, and I will fix the wire.
Okay.
So, Aman, is this sheath similar to the expandable sheath that we get with the Edward valve? Is this a 14 French sheath or?
Yes, this is basically a 14 French sheath, and it's named as a Python sheath because it can expand up to 21 French and accommodate valves up to 29 millimeter size.
This is
and when the valve comes out, it collapses back to 14 French.
This Python sheet is used, one Python sheet for one size of Python sheet used for all sizes.
So as we are going with a 26 millimeter valve, we are pre-dilating the Python sheath so that if we create a severe aortic regurgitation after pre-dilatation, passing the valve does not become very cumbersome.
What size dilator you're inserting now?
This is 18 French, sir.
18 French.
But each sheet they give you a small 21 French also, isn't it?
Okay, normally we go with 18 French only.
Okay, remove.
The 18 should accommodate 29 valve easily, right?
Yes. Yes, it is much easier to cross with a valve.
So my fluoroscopy is constantly on because we have one eye on the wire. Professor Abdurashid is fixing the wire and I am pulling out the dilator.
What difference have you noticed between Python and E-sheath of Edwards?
Wait. There is a different technologies. They used Edwards E-sheet and Python, but the main idea is the same. It is an expandable sheet.
Pressure line.
The big advantage of E-sheet,
Flush.
we start with Edwards in 2011. Is unfortunately, this Python sheet sometimes is bleeding due to hemostatic valve, maybe, and Edwards, they have additional sheet for transapical approach. As I remember, Ascendra sheet. Very good, very short. Also, we are doing sometimes transapical cases.
One more.
And but both of them are good and both of them work. But as I know, they did some upgrades of this Python sheet, and now the next generation of Python sheet will look like maybe E-sheet.
Do you dilate E-sheet with a 21 French dilator before you take a larger valve? No.
I don't think so because I haven't used, we don't have my valve and I haven't used the sheath. But I don't think that would be necessary because your 29 valves should go through 18 French very easily. I also routinely use about 5 cc of propofol
Contrast.
inside the sheath. And that makes the
Yeah.
valve delivery very easy.
Yeah,
so I always
sometimes
use
really
the,
helpful.
about 5
Air has
cc of
been removed?
propofol in the sheath.
When do you inject that propofol? Now?
After the balloon valvuloplasty and
Oh,
before
angio.
advancing the valve.
Great.
So
Ready?
now we'll be doing one angio.
This is a cusp
The
overlap
cusp
view.
overlap view, yes.
Let's go.
Are you ready, sir?
Yes.
Okay.
Wait. What is your opinion? Could we do direct implantation or should we do pre-deal in this case?
I would definitely go for predilation. Given the bicuspid valve, all the intercommissural distance is not bad, but I think that you don't want the valve to move just in one direction.
Yes, it is high risk of valve embolization. Yes, okay.
I will give just a counterpoint because just to be controversial at the meeting, we would directly implant. If this was a Sapien Ultra, we would directly implant this. Calcium burden is low. If you've got reliable pacing, you should get slightly lower risk of embolization and stroke. So that's just a controversial, just for discussion, but we would typically directly implant. If there was a heavy calcium burden, if it had been difficult to cross, we would predilate. But
Yes, the main aim for pre-deal, just to create some space, yes, for much easier valve crossing with the transcatheter heart valve. But here, I think we could cross very easily. Yes, the angle of aortic root seems good. And it shouldn't be any problems with the valve crossing, but as you mentioned, really.
My more concern is about the PVL.
PVL,
what
yes.
was the ICD? Was about 26 also, right?
28.
28, yes.
So the intercommissural distance was 28. And that is why I'm a little bit concerned that if we did not predilate, then we might be chasing it afterwards
Okay.
with the PVL.
Okay. And
So if this was a tricuspid valve stenosis, would you predilate or is it all the bicuspids needs predilatation?
With this much amount of calcium and the angle of delivery, I would not predilate if it was a tricuspid valve.
Okay.
But it's because of that fused cusp and whatever gain we can get. I don't think we are going to be able to open the fused area of the cusp. But even if we can get a little gain, probably we can reduce the paravalvular leak risk. That is the reason I would predilate. But again, as Rajiv said, I take his point very respectfully. I think they have a lot of experience and that's another way to do it.
yes, both strategies are acceptable, but Aman previously said we will do predilatation.
Yes.
Yes?
Or any
Okay, let's go.
bicuspid, I'll do predilation.
let's go.
always stick with the original plan. That's a good thing to do.
Aman, I heard you telling, our professor was telling the implantation is going to be almost 95.5 or whatever it is, higher implantation. What is the concern? Is there any baseline ECG defect or anything like that? Is there a baseline
No, the only
RBB
concern is that there is a right-left fusion, so the valve is going to push the non-coronary side, and normally we know that the conduction system, the His bundle, that is all below the non-coronary side. So if we deploy deep, there are chances of some conduction problem. And moreover, the anchoring zone is a bit higher, so we are actually targeting 0-0 implantation.
Aman, Rashid, let me ask
So,
you
Aman,
your advice here. So we have no experience with MyVal. You have experience of many different valves.
Show the arch.
Does MyVal cross as easily as the Sapien valve,
yeah.
or is it more difficult? Maybe a panelist. Not.
Yes, I could answer for these questions. It is very flexible if we compare with the Edwards. Some of operators that this is maybe a little bit disadvantage, but my opinion, we have this flexibility is advantage of this valve because you could manage coaxiality, and you could manage with the wire, you could fix the wire and delivery system and manage this coaxiality, and that's why I think, and it is very easily crossed through the aortic arch. Go.
Another advantage is the intermediate sizing. So in typical bicuspid valves, we can prevent over and under sizing.
Okay, stop.
Aman, where is the wire attached to the pacemaker? How can you show that? I mean, how
Yes,
is
yes,
the,
yes.
Can
We
you
are
show
still
that,
not attached
please?
the pacemaker. Now we are about to. I'll just remove the balloon.
Oh, it's fine. I'll fix it.
The blood pressure.
Now,
seems to be good.
black one, red
focus
one
here.
is fixed here to skin with just a regular radial wire, and the black one to wire. That's all. We could check the pacemaker.
Pace 150.
150 on.
Can you see the hemodynamics
No,
on
we
the
can't.
screen?
No, we can't see the hemodynamics.
Okay, stop pace.
Stop pacing.
It's working. Okay.
Gilbert 3 image.
Please show the hemodynamics and ECG on the main screen.
Yes.
Yeah,
Yes.
we can see now.
Thank you.
Okay. Now we check the pacemaker. Go a little bit
Let's
deeper, maybe.
check it once
okay,
again.
good.
150 again. Just check it once.
Okay.
Pacing on. Okay.
Stop pacing. Okay, 180. Ready?
Pace 180. Pace on.
Okay.
Go up slowly. Go up all the way. Deflate.
Stop pacing.
Pacing off. Fluoro save.
What was the size of the balloon?
20 millimeters, sir. The minimum annular diameter was 20.7. So we chose 20 millimeter for pre-dilatation. When we do a pre-dilatation, we see a waist on the balloon.
Yes,
Which-
let's see again. Yes.
Yes.
This
Can
is
we
a
see
good
the pre-dilatation fluoroscopy again, please?
point. Remove valve, please.
Do you take an injection to see the movement towards the leaflets in bicuspid?
Normally, if we are suspecting possibility of coronary obstruction, then we do a pre-dilatation with a contrast injection. But just for the leaflet movements, we usually do not.
So I use aortogram with balloon valvuloplasty whenever there is a doubt in the sinus size, and the annular sinus match is not perfect, and you are not sure if you want to use extra volume or you just want to use a nominal prep. So with the Edward valve, we routinely use extra volume to manipulate that size. I know you have a little bit more choices in
Yes. Here we're also going to use extra volume. Yes. Okay. Fine.
So 1 cc extra will be around
Maybe
8.5%
2 cc.
oversized.
Add 1 cc more. Yes.
So here the sinuses are very big, so that
Yes.
was not a doubt.
Yeah.
That's why there was no point of doing aortogram.
Yes.
But sometimes you do that. Also, sometimes I do that for Medtronic
1
valves
cc more.
when I'm using that, and if the coronary height is low. That's the other reason. A lot of time to do aortogram simultaneously.
I'll give 3,000, please.
Okay, that's enough.
Aman, do you guys have experience of using the self-expanding valve? Is it available in India?
Yes, we have used Medtronic's Hydra. Hydra is again a made in India valve. It was actually a European valve designed by Vascular Concepts and is taken over by an Indian company. And we have some experience in the Microport's Vitaflow Liberty valve.
Some resistance. Yes. Sometimes we feel some resistance
Yes.
when we
As you can
cross.
see right now, Aman is using all his muscles.
Whenever you are using your muscles to push the valve, make sure that you are holding the
Wire.
end with a short handle, otherwise you can kink it. And the
Yeah.
wire should always be fixed by the second operator.
Yes, it is very
Aman,
important.
you should try the propofol technique next time. You may like
Yes,
it.
I'll try it. I'll try it.
Yes, we use also this technique, and it is really work well.
Okay, now show the aortic arch, go to LAO. So this navigator system in my valve, we have ability to flex the sheath. So when we are going across the aortic arch, show here.
Okay.
How much do you flex? Half?
Yes,
Yes,
half.
usually
Sometimes
half.
we don't use it. Here it is not necessary to use.
So you want to constantly watch the journey in the arch of aorta, and you want
Yes.
to avoid the
You don't want to scratch the
valves
calcium.
scratching the aorta.
Yes,
So
yes,
you use the flax based on what you see on the aorta.
Flex, and usually I pull back a little bit wire, you know, to avoid of touching
To
our
centralize.
valve. Yeah.
Back to cusp
Cusp
overlap.
overlap, please.
So you can see he literally flaxed as he see the need,
Yeah.
as it's touching the arch aorta. We want to avoid touching it because there might be a lot of atheromatous plaque that you don't see on X-ray.
So would you go in one swing
Wait.
across the valve, or you would stop it in the ascending aorta and then cross again?
Yes, we stopped in ascending aorta. Wait.
So now we can stop discussion for 5 minutes till the valve is deployed.
Pull back a little bit. Good. Pace connected. And now I think we could do one angio.
Yes.
What do you think? The level of valve, is that good, or should we go a little bit deeper or higher?
Little deeper, maybe.
Deeper.
I think the faint line is slightly above the edge of, below the edge of the pigtail.
Yes.
So maybe a bit inside.
Yeah, this would be 80-20 when you do this. What do you think?
There will be some foreshortening, so this will be nearly zero, I think.
Yes, yes, I think it is good. Let's
I
see.
think it's
the,
good, and it's
yes,
going to encourage the
yes.
valve, not
Higher.
at the annulus, right?
Yes.
I would say if we can, by using the delivery system, you can make it little coaxial. That might be good, but otherwise also this is a good start position, I think.
Yes, we could use flex system here a little
Yes.
bit. Let me flex. Yes, it works here. Good.
Yeah, that looks much
Much
coaxial now.
better. And a little bit back maybe. Good. Now it's good. Okay.
One more angio.
Invariably, bicuspid valve are very slow expansion.
Wait,
So
wait. Maybe we'll do one angio on pacing. Yes.
that's a good idea.
170 pace on. Wait. Okay. Okay, pace off. Good.
That's going to be
So
zero.
this confirms that the valve remains stable.
Yes.
we
Maybe
are
we'll
able
do
to
a
get good
little
blood
bit deeper,
pressure.
maybe. Yes.
Slightly in.
Yes, slightly deeper because we have some. Okay. Oh, it's gone.
Probably 1 millimeter down. This looks good.
Just. Okay. Yes, it's better.
Yes.
Okay, ready?
Are you ready? Yes, sir. Okay. Fluoro is on. Pacing on.
180.
Inject contrast. Go up slowly. Go up all the way. All the way. All the way. 1001, 1002, 1003. Deflate.
Deflate. Stop pacing.
Pacing off. Fluoro save.
Almost 90-10.
Pull back. Slowly.
There's some bundle branch.
Pull back. Pull
We
back.
started seeing some bundle branch block once the valve delivery system was placed, but I think this should recover.
Yes, this
Yes.
happens sometimes. It
You
goes
know,
away.
it happens sometimes even after wire crossing.
Yes.
Yes. The VPC is because of wire? You
Yes,
wanna
yes,
bring-
yes. It's because of the wire, most likely.
Okay, this is a cusp overlap view. Let's see coplanar view. We have still a little bit waste here. And what is your opinion? Should we post-dilate maybe with the same balloon again? A little bit
Do you
cranial.
want to pull the pigtail up?
Yes, yes.
Yes.
Let's get the parallax off.
Yes.
So
I think this double tap technique is becoming increasingly popular now, two inflations. But I think if you look at your
Pigtail is on
deployment,
the
there's
top.
clearly recoil when the balloon comes
Yes,
down.
it will not help because
Exactly.
this fused trophy, even it is impossible to cut even with the scissors. We just increase the risk of.
Exactly. So maybe an echo-based decision or would be useful here, PVL and gradient. Do you think that's worth doing at this point?
Yes, we'll do one angio. Let's remove the delivery system. First this one, good.
Do you wait for like 3 minutes from the inflating the valve like you do for the Edward valve? as to allow those outer skirt to take effect?
Yes, we could wait, we could discuss.
Can do an echocardiogram in the meantime.
We'll do the echo at the last, after angio is done.
So Aman, this is excellent demonstration.
Thank you,
This
sir.
is how any very, very seasoned institute will do. You had a perfect control, and congratulations, really very well job done.
Thank
Let's
you,
see
sir.
more with the aortogram and echocardiogram. But
Okay.
as you can see, there was
Lima?
one command and
Lima?
one control during the valve deployment, and the whole team works together.
Now ACG, I think it is much better.
Yes, the complexes are getting narrower.
Lima?
There's a very good dichrotic notch, so I hope we are not going to see much PVL.
Now we'll change to, we'll remove the wire and we'll do one angio. Okay.
So I have not used this delivery system. Is it easy to reinsert? Let's say if you wanted to use the same delivery system with extra cc of volume,
Yes,
Yes,
yes.
yes.
because you cannot do that with the
Edwards,
Edwards
yeah.
because the valve is loaded
Okay, wait.
proximal to the balloon in the Edward,
Pull
and
back
here
out.
I see the valve is loaded on the balloon. So big difference.
Okay, we could fix it in LVOT.
Yes.
Okay, remove. Remove. Fluoro. Okay, ready?
Let
for
me go
one
down
angio?
a bit.
Okay, good. Ready for
Yes.
angio?
Please inject. So we don't see any leak.
There is
It looks
no
quite good.
paravalvular leak.
And
There
in
is zero
coplanar
paravalvular
view?
leak.
Coplanar view?
One coplanar view, please.
Yeah, cusp overlap view. More caudal. More. Good.
We can see at the raphe there is slightly under expanded valve.
Yes,
So we don't
yes.
need to do anything for
But
that.
that raphe is so hard, even surgeons cannot cut it. So if you try to post dilate more, the valve will rupture on the non-coronary side.
It's true.
Ready?
It looks beautiful.
Even I add 1 or 2 cc more, and that's why I think this waste is acceptable.
Yes.
What do you think?
I agree with you. This waste is completely acceptable. I think we are still, if we measure the gradient right now, it's going to be in single digit.
Okay, let's measure the pressure to here and pull back. This one, we could use, I think, this one, yes, Aman?
No, this one is.
And I think you
yes,
guys-
this one we can use.
Yes.
You guys deployed the valve exactly where you had planned. What you had
Yes,
discussed
yes.
before the
Looks
procedure.
Zero.
Very high
That's exactly where
implantation.
you deployed the valve.
Now ACG is good.
The only
Yes.
understanding in my valve is about the foreshortening. So you need to know how much the valve foreshortens.
It's a beautiful result. I mean, every TAVR I see, I just think,
Yes.
not long ago, these patients were in the
one line
hospital
here,
minimum
the
1
pigtail.
week, recovering at home
Yes.
3 months, and older patients would not get this treatment. And now patients will go home same day, next day with a new valve. It's just truly amazing technology, and a fantastic result. I mean, look at that, perfect positioning, no AR, conduction normal, really a very, very greatly done case. Well done.
Thank you, sir.
Now we want to measure pressure. We forgot to measure pressure before the procedure.
The LVD appears pretty low, so
Yes, ADP seems
Is it
good
on?
here.
I routinely use that on a pre and post to judge
Okay,
the procedure.
yes.
So we have the pressure tracings on the screen. Can you appreciate in the panel?
No gradient.
Okay, it's good.
Great job.
Excellent.
Great job. So can we see the closure also?
Yes, we are going to demonstrate the hemostasis, and then I have some discussion on when to choose TAVR in a bicuspid aortic valve.
Gilbert, want to?
Two things. When do you do the echo, and do you reverse heparin?
So normally if we have some event like a proglide failure,
Yeah.
and we think the bleeding is not going to stop,
Fix the mammoth.
that is when we think about reversing the heparin fast. Most of the times we do a digital subtraction angiography to make sure that the local site is not bleeding.
Please, angioceal 8 French.
In our center, we use one femoral, one radial axis.
Yes.
So that leaves, less chance of another groin. And here, digital subtraction, what do you do from the contralateral femoral?
No. I think it is not necessary.
Yes.
Their second access is left radial.
Dr. Chef, can you come for echo?
8 French. And usually you use protamine before the closure.
So in the hospital where I worked, when I joined, they already had a protocol of routinely using protamine. I don't use protamine if I have a good hemostasis. And I use two percloses regularly, so if the percloses work, then I don't use protamine.
Okay. Maybe we'll do half dose. Yes.
We are given 10,000 units heparin.
Where is
Let's
the-
reverse half.
So is there a difference in femoral complication rates if you reverse versus if you don't reverse, or if you use protamine versus
I don't
if you
think
don't?
there is any data regarding that. Actually, I am not aware.
I don't think anybody has studied that, to my knowledge.
Let's do like this.
Rajiv, do you know anything? You guys are very academic and you try to answer every question in the most detail.
Oh, no, I don't. I agree with everyone. I don't think there's data. It's just difference in practice. So we do the percloses first, and then we'll give the protamine. Because if you need to do some sort of vascular rescue, balloon or something, you don't really want to give protamine. You want the heparin still to be active. So that's our rationale. That's why we do it. But I can understand there's logic to give protamine early as well.
I think it's also, as we can see, that little under expansion at the fusion of the cusp.
Ready?
I think it's also kind
So
of
we
tells
are
me that it
now
was a
going
good idea
to
that we
demonstrate
pre-dilated.
hemostasis with one proglide, one angioceal. Please focus the camera over here.
Ready?
So sir is taking off the python sheath. I am holding the proglide and compressing the femoral artery gently.
Gently, yes. Okay. 8 French. It is safer to use 9 French before to insert 8 French and do one angio through the sheath. If it is a severe or moderate bleeding, you could use the second and proglide. Okay. Wait.
So you don't see any bleeding after inserting the
Okay.
angioceal.
Fix.
So I think this is very good, important technique to pay attention to, as Aman will not tie the suture until angioceal is completely deployed.
Yes.
So he's only having the longer thread that he is pushing against the arteriotomy.
So now we have deployed both
Fix
the
this.
proglide and angioceal.
Okay.
When you see the black dot, sorry, my glove is stuck inside. When you see the black dot coming out,
Yes.
you need to open this, my glove.
Okay.
Thank you. This black dot means that the angioceal has been delivered.
Now here you could see there
You
is
can
no
focus
bleeding.
on the local part. Will we do a DSA from this access?
Okay, relax this one. Okay, together. Cut.
No, I think you need to
So
push the
now
knot.
to cut the proglide, I'll hold both the threads
no,
together,
scalpel.
make them wet. Take the knot pusher, go in and push the cut button.
Okay, good. Yeah. Protamine was done?
Half of the heparin has been reversed.
Compress. Now we'll compress for 3-4 minutes here. There is no bleeding, and I think it's good.
I like to palpate the peripheral pulses after achieving the hemostasis, just to make sure that we have not occluded the artery.
Okay. Okay.
Yeah.
So
Would
this
you?
is-
Sorry, since you had a contralateral access, is it a safe practice to just take a DSA and come back to know
I
whether
think-
cinching?
This is left radial access. Yeah, the contralateral access is in the left radial.
Okay, that's wonderful. Then none.
We could compress for.
There was a very good paper from Italy. The second access does add significant complication from the femoral access. And this being apex heart institution, every time they enter through radial, unless ruled otherwise.
Is it a routine practice to take a stitch like this? Because we don't do this.
Just, to fix the skin, and that's all.
We generally do
They
not take the
discharge the
stitch. I personally like to keep this open because if there is going to be any rebleed, I want to have it come out and see it rather than
Okay.
collecting a hematoma inside.
Okay.
If there was a oozing, we generally use a cocktail of Lido and Epi and just inject subcutaneously if there was a oozing. But this looks like a perfect closure. There is no bleeding at all. There is no oozing or bleeding.
So when would you remove the stitch?
After 5 days, usually we call the patient once for follow-up. That is the time when we remove the stitch and also do an echo.
Okay.
Normally, if patients do not require a pacemaker, we discharge on the second day.
Second
Compress.
day.
I think in US, they discharge after 24 hours.
Yes.
Yeah, we generally
fast.
discharge in less than 23 hours.
Yes.
We about 10% of our patients go home the same day.
Oh, wow.
Oh.
So somehow I'm scared to discharge them on the same day because sometimes I have seen patients developing conduction disturbances on the second or third day.
Professor, what about the stroke rates? I mean, if you discharge on the same day, what is Kintur and Professor can answer this? The stroke rates coming after 24 hours.
Our observation is in the first 12 to 18 hours as the propofol weans off. We only use propofol as the sedation. I don't know what was given here. Can you talk
Nothing.
about that?
We had given a combination of, no sir, we did.
Oh,
Because
okay.
patient was very pain sensitive, so we gave some propofol and some fentanyl, that's it. But he's just on a regular oxygen mask, he's awake, arousable, but feels less pain.
Rajiv, do you guys use additional A-line during the procedure or do you use the A-line just from the access?
Just from the access. We don't do profile, we just do conscious sedation. The stroke question is a really good question because the data shows that not all strokes happen immediately now, but there's a delay in stroke. People don't understand the mechanism, but you can get a presentation up to 72 hours of a procedural stroke. So whether you should keep people in hospital to observe, I don't know if you can justify it for a low frequency event, but it's important that not all strokes, if they're going to happen straight away. It can happen within the first 1, 2, 3 days. But just to say again, this is just a fantastic result. I mean, amazing technology, amazing professionalism, expertise. Did we get an echo? Did we see
Yes,
that?
yes. We are now starting the echo. Please show echo on the main screen.
Now, the last maybe 5 or 6 months, we stopped to do echo, even.
That is too minimalistic. sir.
Because, it is difficult to invite our cardiologists. They are all the time busy. And if we have very good hemodynamic, good angio, no any changes, I think usually they are doing echo. We have an echo standby all the time.
So you have to put camera
So
here.
what the best way to see your result is a hemodynamic.
Come here, please.
Absolutely correct. So in our center, we use echo at the bedside.
I think, still in our settings, doing an echo immediately after post-deployment, just a pericardial effusion and the valve functioning gradient and leak, and also at times the wires
this
can
on the
cause
main
some
screen.
injury.
Radial spasm. Yes.
Yes, you could show pressure for them.
So do I understand correctly? I don't use this valve, but there was a large study that was recently published in last 3 or 4 months about the my valve being non-inferior to the Sapien 3.
Yes,
Is
yes,
that
the
correct?
landmark
Yes,
study.
yes. But now we should wait for long-term follow-up.
Is the echo gradient
5,
visible
10
on
years.
the screen?
It's beautiful.
So the velocity we have achieved is 0.98 from 5.3, and let's trace the gradient.
Can this camera come back a little bit? We're not seeing the value.
Can you come back? Focus the whole screen.
Yes, thank you.
Omar Abbas did a lot of work from Beaumont on the difference of the
mean gradient
recovery on
is
the
2.
echo versus the direct measurement.
Yes, yes, it is a different by echo and invasive gradient.
We had 0 gradient on a simultaneous pressure measurement.
Okay, can we see the valve in short axis? Okay, there is some issue in creating the window. Yeah, we can stop here, no problem.
Okay.
I think Aman, congratulations to the entire team,
Thank you,
Dr.
sir.
Professor,
Thank you so much.
Kintur, the whole anesthetist team. Excellent demonstration.
Thank you.
And bicuspid made look so simple and absolutely picture perfect result.
Thank you, sir.
Congratulations
Thank
to the team.
Thank you. Thank you.
So, sir, now we have
I
a...
would like to learn from Aman. Aman, you had some slides prepared for the bicuspid valve.
Yes, because
If we
there
can go
are
over
a lot of junior cardiologists in our delegate list who I think will like to know when you choose transcatheter aortic valve replacement over surgery. So in context to the case that we performed today, let us take a look at some learning points. So TAVR came into practice after partner trials. Initially, the trials were done on a prohibitive risk cases, then high risk, then intermediate risk, then low risk, but it wasn't focused on bicuspid aortic valves.
Compress for 5 minutes.
In the Western world, majority of the cases which went for a TAVR were tricuspid aortic valves. And if I talked to Dr. Kintur Sanghvi that in your institute, if you have 80-year-old male patient, what is the probability of him having a bicuspid valve?
It's very, very unlikely.
Unlikely. And here, even in 80s, we see around 40-50% patients coming with bicuspid aortic valve. So we cannot straight away apply partner trial to bicuspid aortic valve because we have to make sure that certain morphologies which are associated with adverse outcomes are excluded before considering patients for TAVR. So if we look at a subgroup analysis of partner 3 bicuspid registry, all patients were low risk. The slide is visible to you. This analysis showed that at the end of 1 year, TAVR for a bicuspid as well as tricuspid valve had similar outcomes. But we need to know what they had excluded. They had excluded patients with extensive raphe and subannular calcification. Next slide, please. So this is the raphe. Just having a raphe on a valve which is calcific with bulky or linear calcification covering more than half of the raphe, or leaflet calcification volume on CT on one leaflet more than 382 millimeter cube. These two parameters, if they are there together, they are associated with very much adverse outcomes, like 25% mortality at the end of 2 years. If there is one of them, then mortality is 9.5% at the end of 2 years. and if there is nothing, like the patient we had today, calcification at the leaflet was moderate and raphe calcification was mild. So in these kind of patients, the 2-year survival mortality is less than 6%. Why this happens? Because in bicuspid aortic valve we know that bicuspid aortic valvulopathy is a valvulopathy with aortopathy, and the media of aorta is weak. Sometimes you have patient with ascending aortic aneurysm, aorta measuring more than 40-45 millimeter. If you consider TAVR in these patients, there are high chances that after 5 years that patient will come to your hospital with acute aortic syndrome. So such patients who have a dilated aorta should ideally be treated with aortic valve plus aortic root replacement. You consider TAVR only if they are prohibitive risk for surgery. When there is excess raphe or leaflet calcification, there is a high probability of asymmetric valve expansion, paravalvular leak, as well as annular rupture. Next slide. So this is a Bavard registry based on which we consider sizing in bicuspid aortic valve. There are 3 types of anatomy. You compare the ICD, the intercommissural distance, with the annulus diameter. If both are same, you size the valve based on the annulus. In patient that we had today, the anatomy was flare. The annulus is small, the ICD is big. Again, you size as per the annulus. You cannot size as per the ICD in this case because the anchoring is going to happen at both the ICD as well as annulus. But in tapered anatomy, with a small ICD and large annulus, the anchoring predominantly happens at the ICD. So sizing should be based on the ICD to reduce risk of complications. Next slide. Next. So this is a simple flow chart, a very important take home points, that when you have a bicuspid aortic valve patient, you get a CT scan done. You look at LVOT calcification, leaflet calcification, and raphe calcification. If there is severe raphe calcium, severe LVOT calcium, severe leaflet calcium, if there is aortopathy, then you don't think about TAVR in the first go. You think about surgery. Then you determine the surgical risk. If surgical risk is low or intermediate, then you can send patient for aortic valve plus root repair if there is aortic dilatation, or you send the patient for aortic valve replacement and make sure that surgeon does a root widening, especially if annulus is less than 23 millimeter. If surgical risk is high and you are considering TAVR, you have to counsel the patient about residual PVL, its consequences in long run, risk of stroke, root injury, and conversion to emergency surgery. If you are considering TAVR, you can then think about a self or balloon expandable valve based on the indication. Thank you.
Just one question for discussion. When you prefer to do bento procedure, which sending aorta diameter?
We can't hear you. Hello?
So the question the professor is raising is like, when do you suggest to do root replacement along with valve replacement, and what is the diameter, and the surgery would include the ascending aorta repair versus complete replacement? I think the current guideline is if the patient has bicuspid aortic valve stenosis and if the ascending aorta diameter is above 4.5, then one should consider surgical treatment over the valve.
Yes.
But again, we see patients in their 90s, and a lot of time they are not a good prototype. They are frail. They are not. They don't even pass the eyeball test for surgery, and we take on those kind of the patient, particularly more for symptomatic relief, maybe also for prognostic improvement for mortality. The question is, if we have access to the self-expanding valve,
Yes.
In this bicuspid aortic valve stenosis, which are the cases where you select self-expanding valve over the balloon expandable valve, or vice versa?
So normally in patients who have a small annulus and lesser need for coronary access, probably in long run, we can think about a self-expanding valve, or if the coronary heights are very good.
And it is also very important to mention that self-expandable valve for patient with a bicuspid aortic valve, it is much safer and better hemodynamics. And we should know that usually patients with the bicuspid aortic valve, we should know that this procedure should be the last procedure for patient. I mean, it will be not necessary to use the second valve or third valve, but if we know that this patient will need in 7-10 years the second valve, the choice, if it is possible, if it is anatomy allow us to use balloon expandable, we'll use balloon expandable. And very often, we have ascending aorta diameter 45.
Yes.
Should we do aortic replacement in patient with ascending aorta
So if we
45
look at the guidelines,
routinely, or
for isolated aortic aneurysm more than 50, we straight away advise a root replacement. But then we are talking about a patient who is having severe aortic stenosis and is undergoing surgery. So for such patients, we should consider combined valve plus root replacement if root is more than 45.
Hi, this is excellent discussion, excellent case presentation. Once again, Aman, great job.
Thank you. Thank you.
Ready with the next lab and the next case, so we'll move over to the other lab.
We are going to the coronary lab now, and tomorrow morning, the first case we have is a TAVR case. It's an interesting valve-in-valve case, and we'll be doing it live tomorrow morning at 9 a.m. sharp. Thank you.
thank you.